morning, everyone. Thanks for taking time out of your busy schedules on a Saturday to attend our symposium today. So I have no disclosures, and these are the learning objectives of today's session. So the first one is to be aware of the importance of genetic testing for ovarian cancer patients and their families, to also look at what the GOC precision medicine platform is and its objectives, and to understand the importance of multidisciplinary care for women who are diagnosed with ovarian cancer and the role of genetics in cancer treatment and management. So just a little background knowledge. Genetic and genomic factors are usually the underlying causes of all cancers. Carcinogenesis has been attributed to gene mutations and to cell genome instability, which leads to abnormal cell proliferation and tumors that can be either benign or malignant. This abnormal genetic expression is often multifaceted and are contributed to genetic factors, environmental issues, hormonal influences, acquired infections, radiation exposure, and lifestyle. Most cancers are sporadic and occur at an expected age and account for approximately 75% of all cancers. Penetrance is the proportion of those who will express a given disorder, trait, or disease, such as cancer. Most cancer predisposition genes are highly penetrant, and those with a mutation will have increased risk of developing cancer unless risk reduction strategies are implemented. Recognizing hereditary cancer predisposition in patients and identifying those who may benefit from genetic assessment is important in order to minimize or reduce disease burden. Familial cancers are the same type of cancer that occurs at an expected age in younger or more than one close relative on the same side of a family. And these cancers account for approximately 10 to 15% of all cancers as a result of environmental, lifestyle, and genomic influences. The Human Genome Project in 2003 was a project that was an international effort in order to sequence the entire genetic code of the whole human organism. It still remains the largest world collaborative effort, launching biotech and pharmaceutical companies into a whole new direction of research. And with this technology advancement of sequencing the human genome, the ability to identify genetic abnormalities associated with cancers has changed the cancer landscape. It focused on a shift from single genes, such as the BRCA1 and 2 gene that was identified in around 1993-94, to that of mapping the entire genetic content from a physical and functional aspect, and has become the catalyst for evolving personalized medicine and risk reduction. Genetics and genomics is also beginning to direct care in terms of developing and screening and surveillance guidelines for identified high-risk population. It also is becoming treatment guidelines and prognosis for certain cancer types. And examples of this would be BRCA, Lynch syndrome, and HER2 status. So patients are coming to clinics very well informed. I don't know if you've had that, but many of them are very aware of changes to the cancer landscape. They know about immunotherapy, they know about clinical trials. And just while working on this presentation, when I went through the hospital lobby, I picked up the hospital news, and there's this full paper on precision medicine. So this is available to patients to pick up in the lobby as well. So they are reading this information, coming to clinics, fully aware that there are advances in cancer treatment that they wish to be part of. So the National Cancer Institute has defined personalized or precision medicine as a form of medicine that uses information about a person's genes, proteins, and environment to prevent, diagnose, and treat disease. If we understand how genomics are currently influencing healthcare, we can influence the way that we care for our patients and their families. Precision advancements such as genetic testing are focused on platforms to calculate risk, to contribute to diagnosis, to classify tumor types, and to predict recurrence, metastases, remission, and ultimately morbidity and mortality. It will also help identify response to treatment for certain individuals. In 2012, Genome Canada, in collaboration with CIHR, Canadian Institutes of Health Research, funded 17 innovative health projects that promoted precision medicine. Despite these advances, a cohesive national strategy needs to be embraced in order to ensure that these advances are affordable and accessible nationally. And the two areas that they feel will develop very quickly will include prevention and prophylaxis, diagnosis, and appropriate treatment and testing for rare genetic disorders. This paradigm shift in treatment from conventional standard therapy to precision medicine will change how we care for patients. So without precision medicine, we have a group of patients that we identify, and they all have the same tumor type, and so we give them standard of care, and they get the same chemotherapy. A group from that cohort will have a benefit. Another group from that cohort will have no benefit, and some will have adverse effects. With precision medicine, the patient would have their tumor tested, and DNA tests would be run that will help further narrow their treatment to say that this medication would have the most benefit and potential for response. And so each patient will have an individualized plan and treatment, hopefully encouraging response. So the implications of personalized precision medicine will require restructuring of the way that we deliver healthcare now. And with that, it brings important implications for us as nurses. It'll require us to have a current knowledge of the evidence in order to care for patients, as we will be in the front line of implementing any new changes. So why is this so important in gynecology? Well, we know that ovarian cancer is the 5th leading cause of cancer deaths overall, and that less than 50% of ovarian cancer patients will be alive at 5 years. What complicates things further is that there's no reliable proven screening techniques available to screen the general population for ovarian cancer, and that is similar or quite as effective as cervical, colorectal, or breast screening programs that we currently have. Given the mortality of ovarian cancer, it's therefore imperative to identify those who may be at increased risk in order to implement genetic testing and screening for asymptomatic women and implement interventions with prophylactic measures in order to promote risk reduction and lethality of disease. So I'm sure everybody knows about Angelina and her story. So in 2013, she revealed that she had undergone a double mastectomy to reduce her risk of developing breast cancer. After that announcement, the US had a 40% increase in women who were seeking BRCA testing. It was dubbed the Angelina effect. Further to that, in March of 2015, she shared with the world that she had undergone a bilateral prophylactic salpingo-oophorectomy. Her mother passed away at age 49, and following the recommendations that prophylactic surgery should be done 10 years prior to the onset in a relative, she decided to proceed with the surgery in order to reduce her risk of developing ovarian cancer as a result of her known BRCA status. In 2014, subsequent to that, the GOC began discussions about BRCA and the role of using PARP inhibitors as a treatment for women who were diagnosed with a BRCA-positive, platinum-sensitive, relapsed epithelial ovarian cancer. During clinical trials of PARP inhibitors, it was found that some patients had unexpectedly long durations of remission and benefit over and above standard chemotherapy. But one of the limitations that was discovered at the meeting that was held in December of 2014 by the GOC committee was that there was no standard process as to when patients would be referred for genetic testing, and the fact that often testing took a very long time and in order to get the testing and the results back. Further to that, at the meeting we held in November of 2015, the GOC decided that they would have a position statement that no woman would be left behind, with a goal that 100% of high-grade ovarian cancer patients would have their BRCA status known within 3 months of diagnosis. So this is a busy slide, but it does cover the goal of the GOC. The first initiative of the GOC Precision Medicine Platform will be a multi-year program, and it's called BRCA Testing to Treatment, that will help champion BRCA testing for ovarian cancer patients and prevention in family members that are carriers. This will require many levels of GOC engagement and stakeholder partnerships in order to meet the goal of 100% of high-grade ovarian cancer patients having their BRCA status known within 3 months of diagnosis. As we said before, the main driver for this initiative is the lack of integrated and collaborative national platforms regarding BRCA. So we're in the 2015 and 2017 stage right now, where we have different levels of referral. So patients are referred at diagnosis, post-op. Some patients are being referred at recurrence because prior to they hadn't been referred for genetic testing. And some patients who are high-grade and cured of their cancer can be referred now for genetic testing. This is germline testing, so it's a blood test at this point. The goal will be, and hope, in future BRCA somatic and germline testing, where on pathology, reflex referral will be made if a patient's status is known to be positive, and even if the status is known to be negative, they can be referred by the gynecologic or medical oncologist to have germline testing, because there is a proportion of patients who will still be positive on germline testing, but not necessarily somatic. With that information, they can then be forwarded to their families in order to do family prevention and then ultimately guide further patient treatment. So the GOC also has a clinical trials ecosystem and precision medicine platform that they've rolled out. And one of the new endeavors is to build on the capacity and utilize biomarkers to drive personalized medicine, which is currently rapidly advancing opportunity in research and treatment options for many patients. This platform is intended to enable patients to or enable us to partner nationally to have access to novel therapies and ongoing research opportunities. The GOC's mandate is to act as one of the stakeholders that can enable harmonization of efforts so that across the landscape we can identify and close gaps in knowledge, processes and system delivery, technology and trial designs, and community integration and alignment so that women nationally will have access to programs or opportunities. So hereditary syndromes only account for approximately 10% of epithelial ovarian cancers. A hereditary cancer syndrome is suspected if the age is less than 40 at diagnosis, has a history of prior breast cancer, or has a strong family history of other cancers, particularly in immediate family members. However, research is telling us that there is a small proportion of women who will test positive for BRCA despite a negative personal health history or family history. Germline BRCA mutations have a distinct biological and clinical behavior that can directly impact on treatment. BRCA is associated with better prognosis in response to platinum-based therapies and may be less responsive to taxanes than non-hereditary epithelial ovarian cancer. In the general population, the risk of BRCA status is in approximately 1 in 200 people that will carry a mutation in one of the genes. But there are some ethnicities that will have an increased incidence, one of them being the Ashkenazi Jew population, where the prevalence is 1 in 40, and other groups that have an increased risk of BRCA 1 and 2 mutations are those of French-Canadian background, Mennonite, Icelandic, and Scandinavian backgrounds. So women with a diagnosis of ovarian cancer have historically been offered genetic testing if several family members were identified on a health history. But new evidence, as I had stated before, is suggesting that we need to change that practice, and we need to determine a woman's status prior to or at the time of diagnosis in order to help plan her treatment, not only initially but in the future. And this will be referred to as treatment-focused genetic testing. So the objectives of doing a cancer risk assessment, and this is often done by genetics counselors, but in smaller centers may be done by the nurse, is to define cancer risk for patients and their family members through detailed personal and family histories, identifying those who may benefit from a genomic testing, to provide risk-based cancer screening and risk reduction strategies, to assess the psychosocial and cultural implications of risk assessment and sharing that information with extended family members, and providing education, counseling, and psychosocial support in order to facilitate informed decision-making, not only about the testing, but what to do with the results afterwards. So previously, indications for a referral were that anybody who identified it as an early age of cancer, earlier than expected, anyone that had the same type of cancer in 2 or more close relatives, constellation of cancers that were characteristic of hereditary syndromes, anyone who had a male breast cancer within their family, ovarian cancer, or medullary thyroid cancer at any age, breast cancer in women of Jewish ancestry, and those who had previously identified cancer-associated mutations in their family. Genetic testing is sometimes medically necessary when test results will assist with diagnosis and or medical or surgical management of patients and or families. High-grade serous cancers, regardless of family history, should be referred, as many have been proven to have no family history. So what are the challenges in discussing genetics? Well, ideally, patients should be identified and considered for genetic testing as soon as possible at diagnosis. However, we all realize the challenges we face in clinic, and sometimes there's multiple demands and distractions that prevent a robust discussion about genetics despite our good intentions. The role for multidisciplinary referral of a patient with informed consent regarding options and rationale for referral will greatly help in move this forward. However, we have to also take into consideration the timing of having these discussions, because at diagnosis, sometimes patients are overwhelmed and are not able to absorb the reason why we want to move this forward. One of the other limitations is currently there are no established guidelines or consensus with providers to say this is an automatic thing and we need to do this. But we all know that the length of time for referral can take months, and so we want to make sure that we can get the process moving faster so patients can have the information in a timely manner. So Fox et al. Did a survey of women to see when they preferred to have the genetics discussion. And so the majority of the patients said that they would prefer to do that at diagnosis. A smaller proportion said it during treatment, and a very small proportion said 6 to 12 months or more than a year after treatment. Fox et al. Also talked to patients regarding why they wanted to do the testing or why they felt it was important to do the testing. And it's pretty even in terms of response that they wanted the information for their family, they wanted to have a better understanding of why the cancer occurred in the first place, and another portion wanted to have the information because they felt it was important for treatment discussions after. Most women prefer to get this information from their oncology nurse team, and the rationale for that was because they felt that their health team was the one that was designing their treatment plan and was familiar with their own personal history. The delivery of this information should be balanced yet positive, especially when discussing prognostic implications. So what happens if you're not a BRCA carrier? What options are available? So most women do want information regarding implications for testing in relation to personal and familial risk, and they want this information not just verbally, they want it in written information as well. Approximately 50% of women diagnosed with cancer will identify on screening assessment and ESAS that they suffer from depression and anxiety. Adding genetic testing can sometimes increase this anxiety, especially waiting for results. And nursing needs to be proactive in supporting patients and families during times of distress, and ensuring that adequate referrals to meet their needs can be facilitated in a timely manner. Only 10 to 15% of patients who are tested for BRCA will test positive, leaving 85 to 90% of patients testing negative. These patients, while relieved to know that they're not a carrier, do understand that treatment and screening options for themselves and family are limited. So, what is our role? We need to be the forefront of patient care with multidisciplinary team members to ensure that we can deliver personalized care. We need to be prepared to help patients interpret results of genetic testing and subsequent clinical implications. And in order to do that, we need to assess clinical risks. We need to discuss and clarify patient values and priorities, provide information required for information and informed decision-making, and provide support not only for patients, but their family members as well, and how they're going to manage the results themselves, especially in younger patients or younger families. Anticipating these needs and coordinating efforts with other members of the healthcare team will enhance patient experience around genetic testing. We also have a professional responsibility to remain current in terms of cancer and its respective treatment therapies, and our scope of practice has historically been to focus on an individualized plan of care. Patients need to understand what precision medicine is and its implications for treatment, and we'll be in a unique position to help patients navigate through this new and exciting chapter in nursing and cancer care. We also have to have a very comprehensive understanding of the mechanisms of new drugs, including specific side effect profiles, effectiveness, and symptoms in order to educate patients. One of the other factors with BRCA testing is ethical considerations. So genetic results can conjure up more questions than answers at times, and this can present challenging clinical issues. We need to ensure that patients are understanding and have fully informed consent, that they have an understanding for the need for genetic education, not only for themselves, but as professionals, we need to know how to counsel patients and their families around the information, and social risks and scientific limitations that we have in 2016, because things are always changing and an ever-evolving landscape. So this becomes incumbent upon us to understand the basic science behind cancer care. We also need to identify and advocate for patients who would benefit from BRCA testing so that they can have that information done faster. We need to have confidence to accurately counsel patients regarding the role of testing and support patients and family regarding the interpretation of results. So the Oncology Nursing Society has put together some indications of the oncology nursing role in cancer genetics and genomics. And you can see the majority of them are to integrate new practice, educate, promote, and advocate. All oncology nurses should demonstrate education and practice that is consistent. And this includes making sure that we understand the pedigree construction and evaluation, genetic education, cancer prevention, education on risk reduction strategies, lifestyle, and carcinogen avoidance, as well as collaborative referrals for comprehensive genetic assessments. So BRCA in the future, where do we go? Knowledge of BRCA status for patients can provide a guide for novel therapies. PARP inhibitors have shown clinically significant, promising results that are changing the landscape of cancer care, from treatment to maintenance therapy. And in a disease that has such a poor prognosis, this gives hope for a select proportion of the population. Nursing needs to embrace their role in this exciting forefront of cancer care and be prepared to support patients and their families by advocating for genetic testing, not only for ovarian cancer, but for other cancers as we learn more about the role of genetics and genomics in the development of cancer.